Now is a good time to quickly review the three phases of an MI. The beginning phase is ischemia, characterized by ST depression or inverted T waves. This is usually seconds to minutes after the onset of the event. The second phase is injury, characterized by ST elevation. This is usually minutes to hours after the onset. And the final stage is abnormal Q waves, which is the infarct phase, characterized by a pathological Q wave that is greater than 0.04 seconds in duration, or one little box, or the Q wave is deeper than 25% of the height of the R wave in the same complex. This is usually hours to days to weeks to months or to years old. By knowing these three phases and their characteristics, you can better understand the evolution of an MI. So hypothetically, let's take a 65-year-old patient who has a 10 out of 10 crushing chest pain. He's pale, cool, and diaphoretic, speaking in one-word sentences. After clearing the ABCs and placing the patient in a position of comfort, your EMT partner grabs a baseline SpO2, which is 96%. But because he has dyspneic, you place him on 4 liters per minute of O2 via nasal cannula. You want to treat that pain, but you follow your discipline and wait for a 3 lead. It reveals a sinus rhythm with a rate of 76. It's not too fast or too slow. A 12 lead is obtained and you see the series of strips. After confirming that the monitor was in diagnostic mode and the calibration was correct, you glance at the heart rate, which was 76. You then look at the QRS duration, 0.082 seconds. Normal. You now look at the inferior leads for ST elevation. Do you see any? There is no ST elevation, so as long as the patient's blood pressure tolerates it, you can start to administer nitrates. Looking at the other leads, do you see any ST elevation? So, even though there is no other ST elevation, this patient will be treated appropriately, including a code 3 transport, unless the pain completely resolved itself. Remember, a patient does not have to have ST elevation to have an MI. We are just not going to activate the cath lab. Left bundle branch blocks are common, so common that they are the leading ST mimicker. So how can we tell if the left bundle branch block that we're looking at is old or a new onset? If you look at this strip, you will notice that everywhere there is ST elevation, a common occurrence is happening. The ST segment is obviously elevated above the isoelectric line, but also the QS wave is always below the isoelectric line. This is called discordance, or in other words, disagreement. This is a normal finding with left bundle branch block, and all ST elevation complexes will have this trait. To help identify an MI associated with the left bundle branch block, look for a reliable indicator that can have a reliability of over 90%. Concordance, or complexes that agree with each other. This criteria is known as the Scarboza criteria. While there are other Scarboza criteria determinants, concordance is the most reliable and will be the only one taught in this presentation. It's also the easiest to remember. Here, there are 3 different complexes. The one on the left illustrates concordant complexes. Both of these complexes are above the isoelectric line. The other 2 have lesser reliability and will not be taught. These strips illustrate the value of the Scarboza criteria in determining the presence of an MI with a left bundle branch block. While these strips look ominous at first glance, a closer look would reveal that the QRS duration is delayed, which would cause you to look at V1. You see that the terminal complex is downward, which would indicate that this is a left bundle branch block. Now, taking the Scarboza criteria into account, you notice that there is discordance associated with the ST in leads V1, V2, and V3. However, you now find concordant complexes in the anterior and lateral leads V4, V5, V6, and also in lead 1. This would now be a STEMI activation into the cath lab. The Scarboza criteria can also be applied to a paced rhythm as well. Here, a concordant complex is seen in lead 1 following a pacer spike. This would be indicative of a new MI associated with this paced rhythm. This strip shows a left bundle branch block. Is there an MI associated with it? Yes. Lead 2 shows concordance. How about here? How many mimickers can be found here? The QRS duration is delayed, so we look at V1 and it's downward. So we have a left bundle branch block. But do we see any concordance? None can be found. Do we see widespread ST elevation that would be indicative of pericarditis? No. However, there is excessive amplitude displayed in V1, V2, V5, and V6. This would be indicative